Good morning. Welcome to the project presentation of the Leadership Development Program of the APAO. I would like to start the session with not Dr. Vivek Dev actually, Sherman Valero, who is going to be the co-chair. So just to again brief the ground rules, everyone will have 8 minutes, where 5 minutes will be for the presentation and 3 minutes will be for the discussion. So at the end of 8 minutes, you need to conclude your discussion, okay? So we know that you have been working so hard. So this is the time to showcase all your hard work. So wish you all the very best. I would like to invite the very first presentation. Yes. Also, we would like to welcome Dr. Yi Zhong Wang. Yes. Okay. So he's the president of the Taiwan Ophthalmological Society, who will be hosting the master class for the next batch. Okay. So we will start with the first presentation. This presentation is on the Philippine Ophthalmology Residency Training Project, website for training programs and applicant matching. I would like to invite Dr. Raymond Nelson Regalado.
Good morning. Thank you, professors. Good morning, dear colleagues, dear classmates, and we thank on behalf of my classmates, we thank the APAO and the AIOS for accepting us into this wonderful program. So this morning, I'll talk about the Philippine Ophthalmology Residency Training website. For the past 5 years, we've seen an increasing interest in ophthalmology training, especially from the medical students. We've seen a rise in the average number of applicants in the past 3 years. In some centers that I work for, we've seen double the amount of the number of applicants who are applying for residency training. Aside from that, more and more training institutions are applying for board certification to further increase the field of ophthalmology training in the country. Medical students, on the other hand, are not really familiar with all of the institutions that have been sprouting. They are only familiar in the institutions where they rotate in or where their relatives or friends train as a matter of referral system. Also, we are experiencing an exodus of newly minted ophthalmologists outside the main city. So a lot of Manila and internationally trained graduates are moving into provincial practice, which is good. Local and provincial government support for eye care has increased over the past 5 or 6 years because they identified cataract as a major health concern by the National Department of Health and eye care as a deliverable goal. Also, eye centers from new hospitals or from legacy brands are starting to spread out into the provincial areas, thereby improving access to a lot of the advanced training equipment that were once not available to those in the provinces. But we've also seen some unhappy applicants who are really not fit for the programs they are in. But unfortunately, we have no real way of knowing if they are fit for that program until they become accepted into that program. So we've also seen a number of increase in resident dropouts due to burnout or being unsatisfied with your training. So the problems that we'd like to tackle is to, first of all, familiarize potential applicants regarding their training options and introduce the new and upcoming training programs, and maybe somehow align applicant expectations with a training program. So this is the objectives of the iresidencyph.com. So in this website, we have an updated list of board-accredited training institutions, hopefully to increase awareness of the different training institutions, particularly those in the provincial and the new training institutions. Also, we hope to provide suggestions of best fit programs for these applicants. And in the future, we can have a repository of potential applicant profiles to further streamline the application process in the different training institutions. So this website is live but ongoing development. So this is the website. You can access it from your phones. So we have a user account interface where the applicants or the users can have their username and password. And this is a sample of the list of training institutions numbered here. And then if you click a name of the training institution, a small profile page pops up with all the contact information, general description of the training program, and some closing statements. Also, in the end, we have a residency matching quiz, wherein we have 20 questions, and I communicated these questions to the chairs, training officers, and the chief residents of the different training institutions for them to answer the quiz. So mostly these questions are focused on training style, research orientation, patient load, degree of mentoring, and level of independence. The users then answer the survey, and their answers are matched to those answers of the training institutions, and these are assigned points. And the top 5 institutions with the highest scores will be shown as suggestions for the applicant. So some of the sample questions that are included is, what is the primary focus of the training program? Is it more clinical, more surgical, more research-oriented? The patient load, the pace of the program, do you have access to advanced technology? What type of patient demographics do you cater to? The learning style of the training institution? Is there a mentorship program? And what type of applicant background is the training institution looking for? So we are currently finishing the website. I already secured the sponsor because it's quite expensive. 19 out of the 36 institutions have already submitted, but others are still submitting. And the future plans for this is to have a validity study on the questionnaire, and I plan to launch by the 3rd of this quarter, which just coincides with the graduation of the medical schools. And maybe we can do a prospective study on residence experience versus the matching quiz. This can also serve as an applicant portal where they can upload their credentials instead of passing on your transcript of records to the different training institutions 20 times over. This could be just a repository for all those documents. Also, the training institution may also want to use this for their own application process. And the ultimate goal is to be adopted by the Philippine Board of Ophthalmology. Thank you for your kind attention.
Do we have any questions for Dr. Regalado? Well, just a comment maybe from me, because I'm part of the Philippine Board of Ophthalmology. So this is one way of doing it, doing the program first and then trying to have it adopted by the board, which is your ultimate goal. The other way of doing it is maybe in other projects that you will do is get them on board right away, because that might be a challenge later on if your goals are not aligned with them. And so you did everything that they may not adopt. But this is one way of doing it, because the other problem with doing it with the board is that they would have a lot of requirements. They probably don't know what it's about. They'll have a lot of doubts about it. So give them the product first and see how you can match it. But the other way of doing it is get them on board right away so that you know what they're looking for. So those are two approaches on doing your projects for all of you who are also doing projects with bigger entities like government or NGOs or your own society, your own society. So that's my comment. So, but very good, thank you.
Okay, very nice project, very good, very useful project, I would say. Just one query. So how did you develop this project? Did you do a pilot study at the beginning, or how did you modify, while doing it, how did you get the feedback? Yeah.
So I did an informal survey of some of the training officers that I know and to develop what type of applicants they're looking for. And fortunately also I'm part of 4 training institutions. So I know the workings, what we always ask the applicants, what the training program always tends to look for. And I also talk to a lot of residents, their problems, the difficulties they're facing, and if they're happy with their training program. So from then, I built this questionnaire, and then for future validity studies, maybe.
Okay, thank you.
Thank you.
All right, thank you very much, Dr. Regalado. Our next presenter would be Rachel Chong, presenting on flourishing index measures among ophthalmologists in the Asia Pacific.
Good morning, everyone. I just wanted to say what an amazing privilege it's been to be among such inspiring companies, so thank you again for the opportunity. So my project really was to examine what flourishing is in Asia Pacific ophthalmologists. And the idea of flourishing is really the intersection between hedonic happiness, which refers to pleasure and enjoyment, as well as eudaimonic happiness, which is this sense of meaning and purpose in our lives. It's important to qualify that this is not just the absence of burnout, because many studies have been done in health practitioners to look at how burnout is affecting us. But this idea of flourishing goes beyond that, while we're exploring how well we are thriving and growing in our respective areas. The benefits of flourishing has been that people have done studies showing that individuals who are able to flourish more are able to contribute more as well in their personal capacities, as well as in the workplace and in the community. So obviously this is a very key area of our own personal as well as professional development that I think more attention needs to be paid to. So this idea of human flourishing was first proposed by a professor from Harvard, Professor Tyler Van Der Wiel. He looked at these various domains, which I will describe as well later. The aim of my study was to look specifically in practicing ophthalmologists who are mainly at consultant level and above in the Asia Pacific, and to identify potential gaps that we may then proceed to address in order to aid our own flourishing. I performed a cross-sectional web-based survey between June and September of last year, and very amazingly was well supported by the LDP network, so thank you to everybody who's been a part of this. So the self-reported demographic data that was collected, including the country of practice, involvement in non-clinical work, age, gender, marital and parenthood status, and countries were then grouped according to their World Bank income classifications, where lower income economies included Nepal, India, Indonesia, Mongolia, Myanmar, Pakistan, Philippines, Sri Lanka and Vietnam, whereas high income economies included Malaysia, Australia, Hong Kong, Japan and Singapore. And we looked at these 6 different domains that included happiness and life satisfaction, mental and physical health, meaning and purpose, character and virtue, as well as close social relationships, and finally, financial and material stability. I'm just going to skip over the questions in the interest of time. We looked at gender-specific differences in well-being that was also self-reported in terms of which factor people thought was most important in promoting their well-being, as well as interventions that they felt would be most helpful in their institutions to promote flourishing for them. In terms of the results, we eventually got a total of 52 respondents from 14 different countries. And the top-ranked factors that were thought to influence the flourishing of practicing ophthalmologists in Asia Pacific were limited professional autonomy, lack of work-life integration, and a lack of a supportive work environment. Positive interventions that were meant to be helpful included relationship practices such as job crafting, promoting behavioral exercises via acts of kindness, as well as other efforts to protect family relationships and encourage gratitude. When we looked at comparing the effects of gender on flourishing, just very broadly speaking, it looked like females were flourishing less than their male counterparts. But when we looked at the breakdown in terms of the income of the various countries of the respondents, it then became apparent that it was mainly the females and unmarried individuals in the lower income countries who were reporting lower scores than their male counterparts and married counterparts. When we further looked at the effects of age on flourishing, it is quite clear that ophthalmologists who were more than 60 years old were much happier than people who were younger. So, I mean, this is actually concurs with many aging studies. You know, it has been suggested that once you're more stable in your career, you've reached greater social stability, you tend to be happier. So I hope everyone is encouraged that the best is yet to come. And this is just a graphical representation where you can see that the most marked differences is really in graphs A and B, where it's the females and the unmarried ophthalmologists in the lower income countries who were reporting lower flourishing scores than their male and married counterparts. So where do we go from here? I feel that the study has raised some questions about how we should be supporting our colleagues in specific situations. Gender studies would be helpful for identifying specific reasons for negative well-being in family ophthalmologists, and perhaps increased measures are necessary to protect families and familial relationships, particularly in lower income countries. Married ophthalmologists in higher income countries actually reported lower flourishing in terms of financial and material support, and this may be related to the greater costs and considerations of starting a family in higher income countries where cost of living is higher. Also, clearly there's a need to look at age-specific concerns of younger ophthalmologists to try and identify areas that may be able to promote greater flourishing in our younger colleagues. So thank you very much. Just a plug for APGC, which is in Singapore next year. Please come and join us if you're free. Thank you.
Thank you very much. That was a very good presentation. And it involves current day situations involving everybody in the society. So, out of the measures you have underlined, what do you think is a practical intervention that from this study you can tell us?
That's a great question. I think institutions, to begin with, can recognize the importance of good familial support in ophthalmologists being able to contribute more at the workplace. So things like recognizing that there may be seasons of life, you know, parents of young children, for example, where they may not be able to contribute as much, but it doesn't mean that later in their careers that they wouldn't be able to make up for it. Yeah, so I think just management and institutional recognition of these issues is key.
Okay, thank you. Any other questions from the audience?
No, I think that's a really interesting question. So I suspect culture has a big part to play in it, and also generational mindsets matter. So if you have good role models that you can look up to as a female who are already in positions of leadership, who are able to afford mentorship and supervision to guide you in the way, then that's a very powerful statement. The other thing is, it's not just the females who can empower females, but also males like yourself, you know, who recognize that there's a need to bridge this gender gap is going to be very helpful for future generations of female aspiring leaders. So that's a great point, but I do think it will probably take time after the recognition of these issues. Yeah. Thank you.
So just one more. If probably in the future, I don't know if there are any studies that are being done in other specialties as well. It would be interesting to compare across specialties how ophthalmologists are doing compared to surgeons, compared to, you know, pediatricians. That would be interesting as well, because it's also a specialty specific, I think, factor. So
that's right.
Yeah, very interesting. Thank you.
Thank you.
So we are going to the number 4 topic. The speaker is Professor Pei Kang Liu. He's from the Kaohsiung Medical University Hospital in Taiwan. He's going to talking about overcoming challenges in cataract surgery training among residents, an Asia Pacific survey. Welcome to Professor Liu.
Thanks everyone. And thanks our mentor in the past year, and as well as our president from Taiwan Ophthalmology Society. I'm Pei Kang Liu from Taiwan. Today I would like to share the result of my project, Overcoming Challenge in Cataract Surgery Training among Residents. We know that mastery skill is important for the career development. Most of the surgery was performed under local anesthesia, which make the senior surgeon not comfortable to dedicate the surgery to the patient. To the resident, and the single mistake can be very serious. And we know that medical knowledge can be assessed via the board examination, but surgical skill is very hard to evaluate. So try to identify the obstacle in cataract surgery training for residents, and then maybe find some way to improve the training method. We design an anonymous questionnaire consisting of the 35 questions, and thanks to my charismatic help me to distributing this survey, and finally we got to 152 responses. Regarding the simulation training, most residents have the opportunity to animal simulation training. Only 15% have VR training experience. Importantly, 16% do not have any simulation training at all. Most respondents consider the animal simulation training to be most beneficial. When asked about the effectiveness of simulation training, over 80 gave a score of 5 or higher, indicate a positive recognition of simulation training. Nearly 80% have their first cataract surgery exposure by the second year of residency. Over 90% perform their first cataract surgery on conscious patient, which result in a significantly higher stress level. The average stress score was 6.4 out of 10 unconscious patient, but decreased to 3.9 when the patient was unconscious. This indicated the conscious level result in a significantly higher stress during the training on conscious patient. The most commonly first step allowed to be performed was viscoelastic aspiration and the IOL injection. The least commonly dedicated first step is nucleus cracking. The nucleus cracking was considered the most challenging step regarding this of the residency stage. In terms of the specific surgical situation, more than 50% had the opportunity to manage hard and mature cataract, PC rupture, when leakage require corneal suturing, and a small pupil. Most of the respondents expressed the need for more emergency complication management and the proper mental guidance about detailed surgical tips and the detailed surgical steps. The number of complete cataract surgery performed by residents show a polarized pattern. Most had under 20 or over 200. This reflects unequal training opportunity and the training environment. About the confidence in surgical skill, remain moderate. The average score is 5 out of 10, either during or after residency. This may suggest the residency training did not significantly improve the surgical confidence in surgical skill. Over 50% expressed the anxiety related to the surgical skill during training. Over 90% report there's no opportunity to do a training abroad. Most agree that a short-term cataract surgery training program is important for the mature. The average score is 7.1 out of 10. So the major issue identified is a higher patient expectation, which make the senior surgeon reluctant to dedicate surgery to the residents, and the local anesthesia limited practice number. And the most preferred method to improve the surgical skill still remain the more clinical opportunity. So in conclusion, the surgical training in cataract still based on the apprenticeship model, and the stress and the anxiety are common, especially on the conscious patient, and the confidence in surgical skill remain moderate even during or after training, and the simulation-based training considered beneficial but not equally accessible, and there is a lack of standardized assessment for surgical competency. Based on the result, we suggest establish a standardized cataract surgery curriculum, and the short-term training program may be important. And expanding simulation-based training may improve the skill, and improving the mentor training system, and implementing a structured surgical training requirement with minimal surgery number and the case large book. Finally, I would like to thank my classmates who helped me to finish this study and make it possible. And this is Taiwan, from Kaohsiung, is in southern Taiwan, and thank you for everybody, and welcome to Taiwan this summer for the master class.
Thank you, Professor Liu. Can I ask you a question? Oh, any question from the audience? I'm so sorry.
Me? Okay, thank you very much. I really appreciate this project. And then I see the result that most of the register was get stressed when they do patient with conscious patient. But the fact that most of the patient that we do, especially in cataract surgery, maybe more than 90% was done by conscious patient. So what do you suggest for that? Because sometimes if the patient feels stressed, and then we can give the unconscious medication. So we should do the doctor also give that medication or something like that. Maybe you have a suggestion for us. Thank you.
Thank you for the very great question. I think it's a major problem for especially for the initial stage of the resident. For me, like when I perform my first surgery, I shake all the time, and I think that's because now we do the surgery under local anesthesia, so it's very hard for the surgeon or mentor to dedicate the surgery to the resident, and the single step mistake can be very serious, as everybody knows. So I think maybe we can start from the simulation-based training and make every step very familiar, especially like VR. I think with the advancement of VR technique, maybe we can do more real experience about the surgical skill, and then step by step to the surgery, and from the most easiest part, and then to the hardest part. Yeah.
Yes, just a comment. Congratulations, a very comprehensive study. I think you can take this forward by publishing this data, because it's actually first-hand information from all the colleagues from the region. So I think you should take it forward and publish. Yeah.
Okay, you have a question from the boss.
My question is, when did you train your residents by yourself? I mean, your first year resident or second resident?
For me, actually, I like the second. So my first exposure to the
which step you let the resident?
IORO injection, and I'm the under 21.
Okay.
All right, thank you very much. Christopher is here already. Yeah. So up next, we'll ask Dr. Christopher Go to talk about his project on evaluation of the health economics and patient experience of day one post-vitrectomy visits to assist in the implementation of a national guideline. Chris?
Thank you. So my project is looking at removing day one post-vitrectomy surgical review. So what's the problem that we have? So day one post-operative review is becoming more and more of a problem in the VR unit because of the increased surgical volume. So it used to be that we were doing 2 cases for the whole day, but now we're routinely doing 7 cases. And because of that, we have to see more post-op patients. We're delaying OT or clinic start time. Patients are waiting for a long time for a day one review that often takes less than a minute. And unfortunately though, because of the different age of the VR surgeons amongst the unit, there's a lack of consensus of what should be done. So some of us are doing no day one post-op, and some are doing more than others. And during COVID, or maybe even before COVID, day one post-operative review for cataracts were all sort of out the window for a lot of the different countries, and we are basically modeling to see whether we can do something similar for VR surgery. So just a little bit of background, it is standard of care to have day one post-op review for quite some time ago, and that's because in one of the landmark paper back in 1988, there was more than half the patients have complications. But 1988, they were doing general anesthesia for VR surgery, they're doing large gauge vitrectomies. So a lot of the complications actually come from general anesthesia problems like pain, nausea, and vomiting. That doesn't apply nowadays to when we're doing VR surgery. So 63% of surgeons in the British VR Society did a survey last year, and 63% of us do not see the day one post-op reviews routinely. Yes, there are patients who we will still see, but routinely, so for our routine epiretinal membrane, macular holes, we do not see these patients. And that's because of those things I've mentioned, local anesthesia, smaller gauge anesthetics. We kind of know what the patients are going to do. So that's what we're trying to do, see whether we can change the system within our unit. Like I earlier alluded to, is a large unit with 9 surgeons, so some older surgeons are very reluctant to do that, some of the younger surgeons are more willing to accept change. Patient safety and basically cost effectiveness and patient experience are the 3 pillars that people have been arguing about on whether these changes are good on all these fronts. So because of that, the unit ourselves basically went about finding out, addressing the concerns. So patient safety, what we did as a unit, we went back through the last 12 months, did a retrospective study, and see how many of these patients did we really change management on day one post-operative review. And what we found is that actually if you eliminate those with glaucoma and ocular hypertension, we didn't really change day one post-op review in terms of what we do. So the patients who had day one intervention is because they have high pressure, but those patients tend to have a history of ocular hypertension or glaucoma. Then we looked at, then after that, we looked at, after we implemented allowing not seeing day one post-op and see whether there was increased adverse events, and we didn't find any. And so because of that, we said, actually, patient safety-wise, it's actually okay. But then what about the cost effectiveness and the patient experience? Are the patients going to be too anxious? They don't know what's going on. They will want to be seen by someone to reassure them the next day. All those things need to be figured out before we implement this policy. So we did a literature search. Interestingly, there's actually very little in the literature. So even for the cataract day one post-op reviews, even though a lot of us are no longer doing it, there's actually not much literature to support whether that's safe and whether that's cost effective. But it's just that something that we have done and it seems to have worked, but there's actually not much publication on this. So what do we do? And as clinicians, we don't really know what to do with this. So we needed help, basically. So what we did was we consulted a health economics professor that one of my consultants know, and then we basically came up with a novel pilot study to study the patient experience as well as the cost effectiveness of removing day one post-op review. So what did we do? It's a single center prospective pilot study looking at patients who were the control group, which is the conventional way of having day one post-op review, as well as the routine 2-week review, versus those who didn't have any day one review and just go straight to a 2-week post-op review. The primary outcomes are looking at the cost effectiveness. So we developed basically a survey asking about the cost associated. That includes hotel stay, carers taking off time to take the patients to reviews, transport costs, all those things that we ask about the patients. And then we look at the quality of life of these patients as a generalized to see whether they perceive to be any differences, whether they get a day one post-op review. These are the baseline characteristics. So you can see that they are all very similar. There is more patients in the standard of care group, which is the one with day one post-op review. And in terms of the gender and the age, they're all very similar. Interestingly, distance to treatment center was slightly longer in the standard of care, which would have meant that the cost would have artificially increased because they have to travel further. And we thought that it's important to see whether they had any previous eye surgery, because that would change the patient experience, because maybe they're more happy to not be seen day one post-operatively. So the cost effectiveness analysis we looked at, essentially the first row on the NHS, the intervention group is half the price of the control group because there's one whole clinic review less. And the societal cost was what we talked about in terms of the survey, whether there's hotel cost, travel cost, all those things to look at. In the intervention group, the reason why they have problems is, or not problems, they have cost is because at the they might have called the hospital for opinions, or they have presented to the emergency or pharmacy to ask about their surgeries. And combination of those two, you can see that each patient saved about £100 per patient. And in terms of the quality of life, you can see that there's a very minute difference in that there's slight perceived reduced quality of life in the patients who didn't get a day one post-op review. So what does this all mean? In cost effectiveness analysis, what we actually found is that anything above that red line would mean that they are cost effective, because they are either less cost and more effective, or more cost but more effective. But our study is a little bit different because we remove something, so it's less costly, but it's also less effective. So we don't really know what that really means, but when you look at the probability of the cost effectiveness, it appears that it is helpful. There are limitations to the studies, so we assume that they have same quality of life to begin with. The intangible costs that we talked about, like delayed OT start time, patient anxiety post-op, and environmental costs for travels as well. So summary, we think that there's reduced costs, only slightly less efficacious for the patients, and if we implement this system-wide, it definitely is a significant cost saving. Progress-wise, day one post-op review no longer routinely required, although some surgeons still request for that routinely, but it's surgeon-dependent. We have 2 publications coming to publish that and see what the response is going to be. And we are now trying to get a nationwide policy to say that this is safe and that it is something that's safe to do. Lessons learned from all of this: one, teamwork and collaboration. So when we were stuck about the health economics and the patient experience, we really didn't know what we should be doing, and asking health economics to help us and give us guidance on what to do really helped. Implement change with evidence, as we all do already, and the funding is the part that's probably the hardest, because all of this was done sort of outside of work hours with no extra help available, and the health economists did this pro bono. And if we want to do anything larger study to really make sure that this is working, we will definitely need funding for that. Thank you.
Thank you. Maybe we have time for one question for Chris. I'm not sure if you're aware, but I think the Canadian group did a study last year on eliminating day one as well. And they showed that there were very little difference in terms of complications that happened. So it's very interesting. As a VR surgeon myself, it's really, you know, time consuming to do day one. So very interesting. We'll see what happens with the policy.
Thank you.
Thank you. Great job.
We'll have the presentation number 5, which will be a recorded presentation from Dr.
Hello
Nazli
everyone, I'm Dr.
Gul. The presentation is on enhancing multidisciplinary team collaboration, implementing a retinopathy of prematurity care model in KPK, Pakistan. Over to you, Dr. Nazli.
Hello everyone, I'm Dr. Nazli and I'm working at Khyber Medical College, Khyber Teaching Hospital, Peshawar, Pakistan. I'm presenting my leadership development program on enhancing multidisciplinary team collaboration, implementation of retinopathy of prematurity, multidisciplinary team model in Khyber Pakhtunkhwa region of Pakistan. I have no conflict of interest to declare. I got here early, but I can't see. There are various risks associated with preterm birth that affect multi-system organs of the body, and retinopathy of prematurity is one among them. Retinopathy of prematurity is one of the major causes of preventable blindness worldwide. Management of retinopathy of prematurity requires a multidisciplinary approach. Therefore, we designed this project to enhance clinical outcomes by addressing communication barriers and by improving collaboration among multidisciplinary teams managing retinopathy of prematurity in Khyber Pakhtunkhwa region of Pakistan. This project was conducted between April to September 2024. We conducted this project in 3 phases. In phase 1, we did a literature review and conducted a survey. In phase 2, we developed a team framework and assigned role and responsibilities to each team member. And in phase 3, we monitored the key performance indicators for measuring the effectiveness of multidisciplinary team approach. In literature review, we identified only 3 studies on multidisciplinary collaboration in management of retinopathy of prematurity in Pakistan. To better understand the existing challenges, we conducted a survey that revealed several key communication barriers. The most common was limited time for meeting, reported by 63.2% of the participants. It is because most of the retinopathy of prematurity management is done at public sector hospitals, and though they don't get time for meeting due to increased workload. The next most common communication barrier was hierarchy issues. Trainees and other staff hesitate to speak up due to rigid hierarchy, so there are information bottleneck. The right information doesn't reach to the right person. The other communication barriers that were identified are lack of unified data platform, interpersonal challenges, and technical difficulties. So in phase 2, we focused on building a strong multidisciplinary team. We assigned clear roles to each team member. We set up a WhatsApp group for real-time updates. We conducted multidisciplinary team meetings. We conducted training sessions on retinopathy of prematurity. We developed educational brochures for families of preterm infants. We developed an aid for YouTube to increase awareness among families of preterm babies. We struggled with our administration for obtaining a dedicated landline approval to improve communication with families. In phase 3, we measured our progress using the key performance indicators. We saw a significant improvement in outreach response, which increased from 39.74% to 58.3%. Timely screening also improved significantly, rising from 66% to 74%. There was a slight improvement in timely intervention, and there was a modest increase in follow-up compliance. So the key takeaways from our project are: addressing communication barriers fosters teamwork and collaboration, and structured approach enhances overall care delivery. Thank you. Hello everyone, I'm Dr.
Okay. Yeah, I think that's a very good project, a very systematic, comprehensive project. So everybody can use that for your own ones, and then later communicate with her if you need. So we'll move on to the next presentation.
Okay. Presentation. The speaker is Dr. Yusuke Murakami. I'm so sorry. His topic is development of an interdimensional registry of the Betty Cristadine dystrophy towards the future clinical trial. Let's welcome Dr. Yusuke.
This one. Yesterday I put it. No. Should I start later? Yesterday I put it. Number 6. No.
We have not received the PPT of sir.
Later. I just asked.
They haven't loaded your slides yet. Yeah, just move on. Yeah, 7.
Curie. Oh, the topic of his talk is the performance of public vision centers in Cambodia. Is it correct?
Yeah. Thank you, sir. Can someone assist me the slide? Okay, thank you. Good morning to all, and thank you. I'm honored to be a part of this LDP program. So my project today is like the performance of public vision center in Cambodia, and we look closer to the service delivery, challenging, and the recommendation. So I have no financial disclosure to disclose. So my project is like we start with a semi-structured face-to-face question to the staff. It starts from February 13 to 29 February in 2024, and we interview 6 referral hospitals / vision center across 4 countries in Cambodia. Just for your information, the health system ophthalmologists or eye health system in Cambodia, we have close to 200 ophthalmologists, but there are distribution of workplace, so most of them are stay in the city. That's why Vision Center play a role to help us to deliver the eye health care service to the community and the referrals. We have in 2020-23, we have 29 Vision Center in Cambodia across the country. So in my, what's going I'm sorry, the slide is not in order, but I don't know why. Let's go back. So in 2023, we have 29 vision centers in Cambodia, and in my study, we take 6 vision centers from 4 provinces, including Kampong Trak, Chuk, Kralang, Angkor Chom, Leviam, and Boribo. Most of the vision center has 2 staff that can do the spectacle dispensing or like refraction or make a primary eye care service delivery to the community. Except there's 2 among 6 only has 1 staff to do all those jobs, so that's a burden for them. So the aim of my study is to find out the gap, the strength, the weakness, and maybe we can find the opportunity in public vision centers with delivery. So our method is like we do a semi-structure face-to-face interview conduct with the 6 participants. For the vision center sampling, we are non-probability selection, so we just go randomly. So in my finding, we find that our staff at the vision center, they have ability to do the early detection for the eye problem for the simple things such as cataract, conjunctivitis, pterygium, and something that lead to blindness that they can detect early and it can send to the main center. Also, they have their vision testing and refraction. They also have ability to place as optometrist, but there's a difference in Cambodia. We don't have much optometrists, so we have some type of refractionists that they are nurses and they know how to make the diagnosis, primary diagnosis for the patient, and they also know how to make the glasses to to have the community. So they also can do the dispensing spectacle, and they also there's a referral for the surgery or specialty in case they need some surgery or anything like that. And they also have to reach something into the health system for Cambodia. Plus, they also has the ability to do the health education and counseling eye care into the community as well. So on the other hand, we can find that their weakness, the staff at all vision center, they express their limitation in their confidence level regarding, because we have shortage of staff. Like I mentioned earlier, there's only 1 or 2 at each center. So they do a lot of work, like the workload is high. So sometimes they are at the OPD, sometimes they helping people at the emergency department or in the operation theater, and that's why lead to the long wait to the patient when they come for the primary eye checkup or vision center to get their eye health checkup. They need to wait longer. That reduce the volume of the patient that they will wait longer. So that's why there are less patient coming, and there are also the lack of the awareness in the community. They think that they don't know what is the vision center, what's the service delivery at the vision center, and some staff still have skill limitation. And in the rural area, they don't think the eye health is the main problem, just like compared to, like it's quite similar to the other country. So the gap, limit to access the eye care service. People don't understand how important eye care is, like I mentioned earlier, and people wait too long before they get their eye checked. They think that it's normal when we get old, our vision get altered. So if it's not painful, it's not coming. So some people resist to wearing glasses because they feel it uncomfortable at first, and also they find there are other things that they need to worry about, and not just only glasses. And not everyone who need glasses work in public. There's a social stigma because Cambodia just has a long war, like 3-year civil war. So during that time, people they try to kill the one who educated. So people who wear glasses, they will kill them. So that's why the social stigma is still inside the people mind. If you are like you wear something like that. So this is like we need to fight. So this is the sample of our vision center and our staff. This is how they working. What's going on? So this is how they work. We have some slit lamp, some auto refract machine, some lens dispenser machine. So what is the next step for my study? It's not intervention actually, because it's ongoing. It's not yet finished. The National Program for Eye Health in Cambodia still continue their work, working with the partner NGO in order to fight the blindness in Cambodia. So our recommendation is like for the staff shortage, skill and staff, and we need to enhance. So we conduct trainings for the more staff, and we also conduct we try to educate the general practitioner on the basic eye disease. And also we have like some visionary like monitoring, coaching them at the vision center. This is some activity that we have been doing in the last years, like supervision inspection. We go and teach them how to do all this stuff, make sure they know how the machine working very well. And we also conduct the training for the refractioning. Last year we got 50 more refractioning integration from the training program. And also we have a refresher course on training. We call them back to get a refresher course, make sure they don't forget anything. And also for the promote public awareness to the community, they have the schedule for the community outreach program at least 1 or 2 times per month to go into the community and delivery like screening or something like that, education, what is the importance of eye health into the community. And also we national program work very closely to the partner NGO, and we get a grant opportunity to get new equipment for the vision center. This is our order list, because the matter of time, this is our order list that we got from the grant. And the recommendation, we try to split information and let the people know what is the eye care service that we offer at the Vision Center and how much does it cost. And we will continue work collaboration together with the health staffs, local authority community, with the social service school and health professional to reach everyone, especially children and those who need our financial help. And this is our team and our classmates. Thank you.
Thank you, Dr. Curie. Is there any question from the audience?
Maybe just a comment. I think it's a good lesson to learn for everyone. All of you will be in leadership positions or already are in leadership positions. It's a very big problem that she's trying to tackle, but you start it one step at a time, and you try to do small scale and then scale it up later on. So you don't get overwhelmed, but identify a big problem and start solving it bit by bit. So congratulations, and we hope to hear more from that.
Thank you.
Thank you. So,
Professor. Dr. Murakami's slides are okay?
Yeah, thank you. Please turn on my, yeah, okay. Thank you. Okay. Hi, everyone. Thank you, Rom, for exchange the order. And it is a bit lucky we do not have the dance session this morning, the light. Anyway. This is my COI. The NCCT is a company developing the new gene therapy drug, and we received the funding. Beta crystalline dystrophy is an ultra-rare disease caused by biallelic CYP4V2 variants characterized by yellow-white crystals and progressive retinochoroidal atrophy. CYP4V2 is a molecule involved in fatty acid metabolism, and it is highly expressed in the retinal pigment epithelium. And these two variants, one is common in East Asian population, the another is prevalent in Asian Indian population, contributes to higher prevalence in the Asia-Pacific region. We previously conducted multi-center observational clinical study of 62 VCD patients. The patients typically lose vision in the middle age, leading to blindness by their 50s to 60s. And a new treatment, gene therapy to replace the normal CYP4V2 gene into the RPE, is in development, and the clinical trial data suggests the visual acuity significantly improved after vector injection. However, the awareness of disease remains low. Therefore, this study aimed to develop an international BCD registry to obtain natural history data, raise the awareness of disease, and to promote patient involvement in research. At the LDP masterclass, my mentor, Professor Linda Tsai, provided me the important comments and questions how this registry helped my country organization and emphasize the importance of public awareness. Also, in group activity, my members highlight the importance of a clear study protocol and the prospective design. Based on this advice, I decided to analyze the small prospective dataset which we already had before finalizing the study protocol for future international registry. So this study includes patients aged 20 years or older and a visual acuity of 0.1 or higher, and the examination items include age, disease onset, sex, genetic information, and visual, functional, and anatomical parameters. And the patient assessed every 6 months over 2 years. Here is the result of one patient who completed the 2-year follow-up, and the progression was not evident in the color founders photographs and IR images, but careful observation of the FAF images, the global expansion of hypo-AF areas can be observed. This is a quantified result of the natural history and the stable BCB and the progression of MD in part of a patient with moderate stages, but in contrast, the expansion of hypo-AF areas were linearly detected in most patients. So this metric is the most sensitive one to measure the progression. Through LDP, I have built a strong network for BCD and ILD studies, and I also joined the Asia Pacific Inherited Eye Disease Network led by Fei Nguyen from Singapore. I've also handled research topic editorial with my friends, and this one aims to address the genetic diversity of ILDs across the globe, especially in the Asia Pacific region, so I'm waiting for your submissions. Regarding patient and public involvement, I'm engaged with patients through seminar, patient society, and I also enjoy the learning with visually impaired learners in the weekend. And the future directions include to establish a protocol for international prospective study, and also working on developing novel treatment using the mouse model, and I will continue to raise the public awareness, and hopefully we can get big funding. Thank you for listening, and a special thanks to my mentors and my friends. Thank you so much.
Yes, congratulations. That's is an example of how you use the LDP to network with other friends and colleagues in other countries. So congratulations once again. Yeah.
Thank you so much.
Okay. Any other questions? Okay, thank you very much. Okay. So next presentation will be presentation number 8, Dr. Hong Ki Nang. Is it okay? The presentation is titled Establishing Steroid-Induced Glaucoma Registry as a Catalyst in Enhancing National Eye Database Towards Improvement of Big Data on Ophthalmic Diseases in Malaysia. Over to you, Dr. Hong.
Thank you very much, Professor Madhu. Good morning, everyone. My name is Hong Ki, and the topic of my project is establishing a steroid-induced glaucoma registry as a catalyst in enhancing the national eye database towards improvement of big data on ophthalmic diseases in Malaysia. So there's no conflict of interest pertaining to this project. So medical registry is an important health data set used for research, quality improvement, and public health monitoring. In Malaysia, we have National Eye Database, which is owned and run by the Ministry of Health MOH, involving 48 public hospitals throughout Malaysia. It is mainly used for cataract competency monitoring among the trainees. However, the NED doesn't have the participations of those outside the MOH, for example, the universities, private ophthalmologists, as well as army hospitals. And it doesn't cover well of the other ocular diseases besides the cataract surgery. So thus this project hopes that we can incorporate in everyone and all the spectrum of the ophthalmic diseases, and we can create a truly reflective of the Malaysian Eye Disease Registry, MEDR, with the SIGR as the first steps towards the improvement of the big data in Malaysia, which is important for the policy making as well as the prevention of blindness policy in Malaysia. So this project is divided into 3 phases, which the first phase is to identify the barriers and the possible solutions in integrating this SIGR into existing NED, and moving on to address the issue of integration and establish the SIGR, and lastly, to expand using the SIGR model to other subspecialty diseases towards the improvement of big data in Malaysia. So in phase 1, I used a SWOT analysis model to determine the barriers and the possible solutions. So the strength of this project is that there's a large member representation and the financial ability of the society, the national society, and the presence of the academicians within the society itself which can aid in the project. The witnesses include the divisive idea within the Ministry of Health as well, and within the society members and between the both systems, and also lack of the leaders to spearhead the project. The opportunities involve this current existing system, which is the NED, to make it easier to integrate the existing system into the current systems. And also there's better collaborative effort between the MOH and the non-MOH side at the moment in terms of the parallel training program as well as conjoined ophthalmology symposium. The threats include the governance concerns, the data privacy and ownership, as well as the financial support to maintain its sustainability. So after the SWOT analysis, so this is a table showing the barriers and the solutions. So for the data and the governance, I need to engage and advocate to the stakeholders as well as the possible decision maker with a written MOU on the data issues on governance. For fundings, I need to find a value for money packages of the vendor or the tech company and identify the potential source of funding to make it sustainable. For this suboptimal collaborative mindsets, I need to advocate to all the ophthalmology members and make them understand this is important and it's for the future of the nations. For the internal issues within the MOH, like for example the rate tips, you need to engage someone, a key person within the MOH itself to smoothen the technicalities challenges. So there was a few rounds of engagement and discussions between the stakeholders, namely the chairperson of the NED in the MOH, the National Society, the technical support team, and myself to understand more about the current NED setup, our idea of the MEDR as well as the SIGR. Upon which we submitted a proposal based on these guidelines and sent to the National Institute of Health MOH for its merit assessment. The proposal underwent a few rounds of revision and submitted back for NIH for reassessment, and the concern about data, governance, ownership, and sharing are also detailed out in the proposal. Furthermore, I also got a support letter from National Head of Ophthalmology Services from the MOH Malaysia. In terms of the financial support, we're able to get the best deal from the vendor with experience, and the society is agreed to support this project. So this is the latest version of the SIGR notification form, which we plan to launch it during the inaugural Malaysian Ophthalmology Scientific Congress, which is supposed to be by end of this month upon approval from the NIH. This is the best platform to advocate of this MEDR and SIGR because this is the biggest national ophthalmology scientific congress in Malaysia, and it's also important because this is the first time whereby there is a collaboration between the MOH, the university, as well as the societies, and from the Army Hospital as well. So my project currently is at the second part of the phase 2. Our achievement so far is that we're able to identify the barriers and solution, engage and advocate the stakeholders, look for the feasible vendor and find support financially, and the SIGR design is to process advocacy activity with fully integration into NED once the approval from the NIH. And in the future, which include to use the data from the SIGR to study the incidence and the association factors, and later on to move on to phase 3 to expand using this SIGR model into other subspecialty diseases, and later on as the backbone for the big data or ophthalmic diseases in Malaysia. Before I end, I would like to acknowledge my supervisor, Dr. Sherman Valero and Professor Lil Shamini, as well as those important in this project. And thank you very much.
Thank you very much for that nice presentation. Any questions from the audience? Any comments?
Congratulations. I didn't think you will get this far because it was a very difficult project to begin with when I was reading it at the beginning, but kudos to you. I think this is really where you see the importance of getting all the stakeholders involved. You know, there's ownership for everyone. So again, another tip for you who will be doing large-scale projects like this. Get people who you will work with, give them ownership of the projects as well. So congratulations.
Okay, let's move on to the number 9 speaker. The number 9 speaker is Dr. Oldman. She's going to the topic is going to is to enhance the surgical skills training among the ophthalmology resident in Brunei.
Thank you, Professor. Good morning, everyone. My name is Dr. Fitri. I'm from Brunei. My project that I had to do was to enhance surgical skills training among the ophthalmology residents in Brunei. So as an introduction, as you know, Brunei is quite a small country. We have quite a limited number of ophthalmology residents. There are only 7 of them, 3 seniors and 4 juniors. So the objective of my project was to assess the current challenges faced by the residents and also to propose targeted interventions to improve the surgical training. So firstly, what we identified from the key challenges, we've asked the feedback from the consultants that were training the residents. There are quite a variable competence levels among the senior and the junior residents. Among the senior residents, they are quite confident in the cataract surgeries and also the surgical procedures, but there are some that needed remedial training, and that goes the same to the junior residents as well. They've also feedback that there were unequal surgical exposures among the residents as well. They've found out that some had more OT time compared to the rest. So the objective for my project was to standardize this training to bridge all these competency gaps and also to optimize OT opportunities for all the residents. So I did a survey to all the residents, and the survey's questions, key questions, was targeted in obtaining their confidence level in performing basic and intermediate surgeries, the current training methods that they do, any barriers to skill development, and also their suggestions for any improvements. So from this survey, we've asked how confident they are in performing cataract surgery and also the ensuing trauma repair. The feedback was that there was a wide gap of confidence level among the residents, depending on which rotations they are. So one of the feedback was that those that were in the vitreoretinal rotation received less cataract exposure training. However, with suturing techniques, there is no issues among the residents, but they do have low confidence in corneal suturing and globe repairs. So what are the training methods that they've encountered during this residency training? So most of the training were live surgery, so 85% of them. There were very limited wet and dry labs training opportunities, and there is no virtual simulation opportunities. There are a bit of peer practice sessions that they do among themselves. Other challenges identified were limited OT time with supervisors, meaning that the list there is no specific OT training list, so it's all the supervisors list, so they had limited sessions with them. The lack of wet lab opportunities, and also financial constraints for overseas workshop and surgical skills training. So the suggestions from the residents were they needed more wet lab sessions before doing live surgeries to get more confidence, funding support for overseas wet labs, so getting grants, increased supervisor debrief sessions after every surgeries that they do, and also peer review, so video-based feedback sessions on their techniques and what they can improve on. So what I have done in terms of the interventions based on the survey, we've started on a short-term basis, a basic baseline skill assessment where the consultants that trained them would do an initial assessment, and we have set up a dry lab setup using a synthetic eye. And I've also organized a structured simulation. So we've dedicated an OT training list weekly. So I've made a specific session for the trainees once a week so that they have more time to learn their surgical training. And we've also introduced a low-cost simulators, which is the synthetic eye. I've also encouraged and started the mentored surgical training where most of the senior would coach the juniors, but in a supervised setting. And we've had sessions where there is feedbacks on their video recordings on their surgical techniques. So post-intervention, I did a repeated survey, and from that survey we found that the confidence level of the trainees have improved a lot more than before. And they are quite happy with the standardized training for all the residents, and they feel that they are better prepared graduates before becoming independent practice. So my conclusion and what are the next steps. So the survey did confirm that there are key gaps in the surgical training. The proposed interventions are quite feasible and it's quite resident driven. I think the next step that we need to do is to get some funding and grants for simulations and surgical workshops. And perhaps some regional collaborations with partners around the ASEAN country. And also, if budget permits, we could get some virtual training modules and get grants and fundings. And that's it. And I would like to take this opportunity to invite everyone to Brunei in November. We have the ASEAN Ophthalmology Congress.
Thank you, Dr. Oderman. Is there any question from the audience?
So I think it's good that you're looking at the problem while it's still a small, it's still a small program, and then start fixing it before it becomes bigger. So good luck on that one. I wonder if there's what licensing issues you have in Brunei that you may do it the other way around. Instead of sending trainees out, you can get trainers in. That could be an option. Depends on your licensing requirements as well. Because some smaller countries do that. They bring in specialists from other countries, maybe go there on locum for like 2 weeks to a month just to train residents and other specialists. I'm not sure what the medical licensure issues would be there, but that's something you can look into.
Thank you.
So might be cheaper than sending them out.
Than sending them out, that's true.
We can hear you.
Thank you for your very beautiful presentation. I think the country, the group of residents is not so big, so it's a good model to implementing the structure training program, and maybe it's easier to change, right? Because the group is not so big, and then can expand to the Asia Pacific region.
Maybe one more thing. A lot of the people here are involved in like the training national scale, so you can probably ask them for help as well, suggestions on how to put everything in order. So I think we have a question.
It's stuck. And then it's about 7 residents, if I don't mistake. And one of the problem that you got because the lack also of the wet lab. So I just wondering why it happened. I mean, is it because of the ophthalmologist also is not enough? Maybe I don't know. I'm not sure. Or maybe it's maybe you can tell us what's the obstacles like that. Thank you. And I'm sure you are very busy because.
Thank you, Andy. So basically, because there is a small number of residents that we have, the amount that you need to get the wet lab it's not sufficient for all, because there's only a little of us, so it doesn't, and then, the cost is not cost effective. So what usually happens is that the previous seniors that are trained are usually trained abroad, so then they come back as a consultant. But I don't think that's sustainable in a way. So I think at some point, because we are so small, we need to start somewhere. So for me, I feel like I need to start building up the training program as systematic as anywhere else.
Like you are catering to? How much?
So there's only 350,000 of us.
Okay. Yes, very good that you have thought of starting it now. Yes, congratulations.
Thank you, thank you.
I think our last presenter Dr. Andy Indira, who will talk about strengthening glaucoma case finding, a comprehensive primary care training and referral program.
Thank you, Professor. Good morning, everyone. Today I'll present my project about strengthening glaucoma case finding, a comprehensive primary care training and referral program. So no conflict of interest or disclosure for this project. And this is the map of Indonesia. It consists about 17,500 islands, and the project will be in South Sulawesi, one district that we call Makassar. And the prevalence of glaucoma based on data in Indonesia about 0.49%, and in South Sulawesi about 0.51%. As a background, Ministry of Health of Indonesia plan to provide all primary health care to support glaucoma services, especially in the new case findings. So the purpose of this project is to providing glaucoma training to find early detection of glaucoma, so they can increase routine IOP check and normal eye morphologic. And then the second is providing data set of glaucoma around public eye hospital in Makassar. And the objective to discuss qualitative finding from interview or survey, and then the strengthening human resources so they can contribute their skill for diagnosing early glaucoma cases, and they can provide referral letter system for comprehensive glaucoma services. For the data collection plan based on glaucoma basic training, assessment of the optic nerve head, and then IOP measurement by eye keratometer or whatever equipment that they have in a primary health care, and assessment of the anterior chamber, visual field assessment because it's done in a primary health care, so they do by confrontation visual field test. So the timelines on this project from July until December 2024. So we done glaucoma basic training for GP in primary care. We do GP in primary care and also nurses because in Indonesia we are lack of optometrists. So most of the thing was done by GP or nurses, and then so they can improve their skill, and then if they can find a new case, so they can send it to the hospital, so we can do comprehensive assessment for glaucoma. So this is the project strategy because in this project was done by the GP in a public community health center, that it was supervised by the government. So the first time that we do that, we do collaboration with the government in Makassar near the hospital. And because we want to train their GP and the nurses, so we have to do like permission from them, and also give tell about the government how important this project. And then this is the second thing after we do collaboration with the government, and then we do the training. The training will be in about 40 community health center around Makassar Eye Hospital. And then this we can see that we do some training for the GP and the nurses. And then after that, we do like survey about their knowledge. So we do survey for the knowledge, and the respondent was about 107 GP and also the nurses. And then we found that more than 90% know that glaucoma can cause blindness, and then the IOP was related to the damage of the optic nerve, but only 60% know that glaucoma can reserve vision. So this is the result of the survey. And then for project sustainability report, because this project is is a public project, so we have to done the internal stakeholder first. So in Makassar High Hospital staff, we make a team, like a teamwork, because there are about 40 primary healthcare that we have to supervise, so we make a teamwork. It's about 12 team that consists of ophthalmologists, GP, and in a hospital. And then this teamwork was supported by the head director of the Makassar Eye Hospital. And how about the external stakeholder? We also asking support from the head of the health services and primary care in Makassar, and they do support this project. So also the major of the Makassar. So they give the government give full support, and then by this we can get about fundings. It's about 12,000 USD to train them in primary health care. So by this budget, we can go. The team can go around in near the hospital. So this is some picture that the team done. Then the team work with ophthalmologists. They teach them, and also the nurses, and we go regularly. Maybe it's about once in a week, but we make many teams, not just one. So this is effective change management. For the short term, in a 3 until 4 months, there is a effective team that we built, and then the second, there is a glaucoma workshop, so they know what is the importance of this project. And there is also MOU between Makassar government and then Makassar Eye Hospital. And for short term also, we make a pocket for glaucoma detection guidebook for GP and nurses in primary healthcare. For the midterm, we assist glaucoma services in primary care, how to use the eye care and how to use direct ophthalmoscope, because it is the equipment that they have. And there is a publication about the knowledge level of the GP and also the nurses. For the long term, is still done now. Of course, we need monitoring and evaluation of this program. And then we hope that patient examination data we can collect by registry. So the result and conclusion, this program will improve their awareness and competency to detect glaucoma cases, so they can do referral system efficacy. And the second, enhance of collaboration, especially from the government, and project funding has to be provided to support this project in the near future. Thank you.
Do you have any questions or comments?
Yeah, a very good project. I just want to invite your comments or elaborate on how did the LDP project help you? You have done a lot of work as teams, involved teams. So did the LDP, getting involved in LDP, did it help? Can you elaborate on what you learned and how you made that into practice?
Yes, of course. When I starting in LDP project, for the first time, I just get confused that what project do I have to make. I think something that is it like project like this, make a team maybe, because and then so I start to maybe I when we do in Nepal, I consult with you all, and then is this project I can begin or not, or I have to choose other project. And then the LDP say that the mentor of the LDP, you can begin with this project. And how the LDP project, from the LDP we learn about how to make a team, and then how to make negotiation, because this negotiation is very important, especially when we asking for fund and asking and how they can collaborate with us. I think to support this the project. So it's really helped me to communicate, especially to the government and someone that is very need that I need their support. I think from the boss also, and not just from the boss, but also from the other the lowest team. I mean, thank you.
So, may I just say that having been here the longest, I think the projects have gotten bigger and better over the years. I'm really impressed with the scale of the projects that you are doing now. So congratulations to all of you, and we hope that the LDP has helped you in some way in mounting these projects, and we wish you all the luck. I see that they're not just bigger, they're more long term. So that's very good. So that really is a testament to the the quality of the candidates that we are getting, and hopefully the quality of the program that we are turning out. So congratulations, everyone. Thank you very much. Photo.